Hello Rosanna, could you tell me about the organisation that you work for, Clapper?
Yes, I'm Rosanna Preston. I'm the Chief Executive of Clapper. That's the Cleft, Lip and Palate Association. It's a voluntary organisation formed 30 years ago as a partnership between health professionals and people affected by cleft lip and palate. And the aim of Clapper is to provide support in a whole range of ways to parents and to health professionals. Although around 1 in 700 babies are born with a cleft lip and or palate, people are often unaware of the condition until it comes into their family. The baby can be diagnosed at the 20-week scan, or when the baby's born, obviously the cleft might be found then. And we really believe that it makes a huge difference to how the parents cope with that diagnosis if they get access to good, accurate information as soon as possible after they find out about the cleft.
So I guess that's why this film has been made, really, to provide that information.
Absolutely. We think it's a really marvellous source of information, not only for the parents but also for the health professionals who are dealing with the parents. It could be that the first person to see the cleft is a sonographer or a midwife on a maternity ward, and they might not have had direct experience of this before, and they might not know the best way to care for the parent and the child.
So it sounds like you've made this film with parents in mind, but also with professionals in mind.
Yes, absolutely. I think they both need to have easy access to this information.
Why particularly make a film to get this information across?
Sadly, sometimes people have a bad experience, and we want to make this experience as positive as possible for all parents who have a new baby. And the benefit of making the film is that people can access it easily, and they can take it away and digest it at their own speed, and they can look at the different chapters that are relevant to them at the right time.
And also, I guess, they can hear about the experiences of other parents who've been through having a baby with a cleft.
Yes, that's really important. We find that parents often want to talk to another parent who's been through the same experience. Even though they get access to specialist care from the cleft team, they want to talk to somebody else who's been through the same thing. We try to provide that in other ways, but this film gives them a chance to hear about parents' experiences.
Who's been involved in making this film?
Well, really everybody. I mean, it goes back to this idea of partnership. So the parents, the health professionals, the families, and Clapper as well.
And I think as an organisation you also help adults, don't you, who've been born with a cleft?
Yes, we're also an organisation that supports adults, people who maybe come back to us wanting further advice or support. So we really support people right through their whole lifespan.
How do people know about Clapper?
Well, they often find out about us from the nurse specialists, from the cleft teams, or from searching on the internet. But once they come to us, they find we can support them in lots of different ways. So we provide information, downloadable PDFs or information leaflets for new parents who want to know more about what cleft lip and palate means. We provide before and after photographs so they can see what happens after surgery. And we also provide telephone support and advice, so they can ring us at any time and we'll take their calls and talk them through what's going to happen with their child. And we can put them in touch with other parents who've been through the same situation, and they maybe meet up and talk about their experiences and meet their children, which all helps to show the parent that the child is going to be able to develop perfectly well, and just to understand what's going to happen over the next few years.
Peter, can I ask you to say a little bit about your role as a cleft surgeon?
Right, well, as you say, my name is Peter Hodgkinson. I'm a consultant cleft and plastic surgeon. I'm one of a relatively small number of surgeons in the UK who operate regularly on children and adults with cleft lip and palate.
One of the common sorts of clefts involves just one side of the lip. In this baby, the cleft is through the lip and the gum, but there is no cleft of the palate. This is the same baby some months after his operation. And here we can see how his nose is much more symmetrical once the surgery has been done. Sometimes the cleft doesn't go all the way from the lip into the nose. This cleft involves just part of the lip, and there's no cleft in the gum. On the other hand, this is a wide cleft that goes all the way through the lip and the gum and extends through into the palate. This is the same baby straight after her operation. After a few months, everything settles down. Eventually, the scar where the cleft used to be becomes quite hard to see. In some babies, the cleft can be on both sides of the lip. We can see that this cleft on both sides of the lip also extends into the mouth, and there's a cleft of the palate. When the central part of the lip is separate from the lip on the two sides, it can push far forward and sit right under the nose. This is the same baby after his lip's been repaired. The scar's already settling down, and the middle part of his lip now sits in the right place under his nose. Sometimes a bilateral cleft doesn't go all the way from the lip into the nose. Here we can see that the cleft involves the lip, but not the gum. This is very soon after surgery, and we can still see the dissolving stitches which haven't dropped out yet. Much later, the scar is quite hard to see. Clefts of the lip occur very early in pregnancy. A baby's face is formed of processes which have to join up beneath the nose to form the upper lip. If the processes on one side don't join together, then this leaves a gap in the lip. On one side the nose and the upper lip are formed, and on the other side there's a gap. As the baby's face grows and the nose and lip become more recognisable, this leaves a cleft or visible gap in the lip. A cleft in the palate is a gap in the roof of the mouth. This is a complete cleft of the palate, and there is a gap in the hard palate at the front of the roof of the mouth and also in the soft palate at the back. This is a smaller cleft, and the gap only involves the soft palate at the back of the roof of the mouth. Some babies and children come to the cleft service with a submucous cleft palate. In a submucous cleft palate, the roof of the mouth is formed, but the muscles are in the wrong place. A clue to a submucous cleft palate is that the uvula or dangly bit at the back may be double. In a submucous cleft palate, the muscles are in the wrong place, and here the doctor has drawn them in to make them easy to see. Sometimes when the cleft of the palate is very wide, it can be quite hard to spot. The palate is formed by the palatal shells which grow out from the side of the developing upper jaw. To start with, the palatal shells point downwards and the tongue sits in between them. A little later the neck straightens out, allowing the tongue to drop downwards, and the palatal shells lift up so that they point towards each other. The palatal shells have to grow together towards the middle of the roof of the mouth and join up. If they don't meet, a cleft of the palate occurs, leaving a gap in the roof of the mouth. Pierre-Robin sequence is a condition where a wide cleft of the palate is associated with a small jaw. Sometimes babies with Pierre-Robin sequence may have difficulty breathing. When the jaw is small and the cleft in the palate is very wide, the baby can push his tongue up into his nose when he closes his mouth. This can block his nose and make it difficult to breathe. This is quite hard to photograph and this picture is not very clear. We can just see though that the tongue is sitting up through the roof of the mouth within the cleft of the palate. When the baby has difficulty breathing, the cleft specialist nurses are there to help and advise. One of the first things that they may try with you is to lie the baby on their side. Some babies need more support with their breathing. One of the next things to try is a nasopharyngeal airway. This is a soft tube that goes into the nostril and through the nose to the back of the throat. The nasopharyngeal airway makes a clear passage through which the baby can breathe, even though his jaw is very small. On rare occasions, a tracheostomy can be necessary to make sure that the baby can breathe safely. The tracheostomy is a tube inserted directly into the windpipe at a small operation. This baby also has a nasogastric tube. This is a tube that goes through the nose and down into the tummy so that the baby can be fed easily even though he may have difficulty swallowing. When there's a cleft of the lip, the muscle of the top lip that should go all the way across is attached to the nose on either side. This diagram shows how the muscle is attached to the nose in the middle and at the side. When the baby cries, this muscle pulls on the nose and makes the gap in the lip wider. After the operation, the muscle is in the right place and goes round and round the mouth. This means that the baby can smile and pout and move their mouth naturally, and this is continued as they grow. When there's a cleft of the palate, the muscles are also in the wrong place. This is a diagram of the palate just before it's about to be repaired. Halfway through the operation, the floor of the nose has been repaired, but we can see that the muscles are still in the wrong place. The muscles are moved to the back of the palate and then repaired. The roof of the mouth can then be stitched up.
In my role as specialist nurse, parents often ask what causes their baby's cleft lip.
You can imagine that we could talk for hours about the precise causes, but the first thing people have to remember is that clefting happens very early in pregnancy, probably within days of discovering that you're pregnant. The problem's already happened. So that immediately deals with some of the explanations people are going to come up with. You know, this is an early slip-up in development of the face.
And most commonly, parents often ask as well, why has this happened to my baby? Is it something that I have done personally? Is it something I've eaten? Or they're often questions that I do get.
Sure. I mean, immediately people are looking for an explanation whenever something's happened to the baby or something's gone wrong. And the first thing they'll leap on is what they did during the pregnancy itself. And usually that's not the answer, in fact, very rarely. But the most important thing, I think, is to, and I'm sure you do, is address the issue of don't blame yourself. You know, that immediately parents think, I've done something wrong. And the short answer is, no, you haven't. Almost always, this is something that you could have done nothing about.
Are there any factors, John, that are related to clefting?
Occasionally, we have an explanation. For example, certain prescription drugs are associated in some cases with clefting, and some drugs of abuse can sometimes cause problems. Occasionally also, it's very obviously run in the family as an inherited trait, so a grandparent and parent might have already had a cleft before. But in the vast majority of families, there isn't an obvious explanation when you take the family history and the history of the pregnancy.
So if it's not drugs or lifestyle factors, what is the cause?
Broadly speaking, this is a genetic problem. Now that sounds surprising because it doesn't usually run in families. And that's because it's lots of genes added together that make a particular baby susceptible. A very good analogy is height. I happen to be the tallest member of my family. My parents are average height. I just happened to get a combination of genes that made me a taller than average person. Now that in itself isn't a problem, but I used to, when I was a teenager, I was always bumping my head when I walked through doors because I was very tall. And if you imagine the same comparison, you can imagine some children, their palatal shelves don't quite grow as fast as they should. But it's just when you cross that line and suddenly they didn't quite meet and stick together that you have a cleft. So you might have lots of people who are susceptible to it, but only very occasionally it fails to happen. Another important factor is that even if you've got the genetic makeup that makes you susceptible, it's the chance factors that we have no control over. If we all ran across the road, some of us would get run over and some wouldn't. So in the same way, some children are prone to clefting but don't get a problem. Others are actually fairly resistant, but just an unfortunate combination of events early in development meant that the edges didn't get together. So in any individual child, it's hard to say exactly which genes did it, but we can say that about 80% of the cause is our genetic makeup, and it's the interaction of the genes that is the key factor. Almost all of the things that you hear about in the media are actually coincidental and not cause. So in fact, at the moment, we haven't got any big worries from the environment. That's not to say they aren't there, but we haven't actually identified any convincing causes, either in the big environment or indeed in the sort of the personal environment. One of the biggest questions I'm sure you get asked is, before I was pregnant, we went to a party, I was smoking and drinking and stuff. And I think the answer there is that almost everybody could say that, and yet very rarely is a cleft occurring. So either they were just very susceptible and that might have been a factor, or in fact it's completely coincidental. And I suspect in almost all cases, whether you had a cigarette or whether you had a glass of wine before you knew you were pregnant is completely coincidental.
In the future, we may be able to answer these questions more effectively now that we've got all the regional centres throughout the country and we've got a national database to collect all this information that parents are giving us.
Absolutely. I think that now that we're able to count and map and investigate more fully, that will answer part of the question. I think the other part is that once we really start to get a handle on the genes that make some people more susceptible, we'll then be able to go back to the environment and look at the influence of the environment on those susceptible people. So the fact is that 99% of people can do all of those things and it doesn't affect them. It's the 1% who are susceptible who we need to identify. And I'm very hopeful that when we can identify the people who have the genetic makeup that makes them likely to get a cleft, then we'll then understand better how we might avoid that by changing their environment, by adding nutritional elements or by protecting them from particular adverse effects when they're pregnant.
Chris, can you tell us a little bit about your role as a specialist nurse?
I'm the lead nurse for the northern region of the Cleft, and Palate service, the Newcastle end. There's lots of clinical nurse specialists throughout the country caring for families of children with cleft lip and or palate. This is normally picked up at the 20-week anomaly scan. We'll follow that family through caring for the mum and the father in the antenatal period and caring for the child and family, often up until the child's 20.
It sounds like there's a lot of preparation and planning and adjustment time after scan before the baby's born. Is that a time when you would be involved with families?
Yes, and adjustment's a really good word because families do have to adjust to this diagnosis that they've been given. Lots of parents, when they're being given this diagnosis, don't even know what a cleft lip is. So then we have to go into detail, and so that they can, formulate plans in their head and they fully understand what's going to be happening.
Does everyone adjust in the time from scan to birth, do you think?
In the majority of cases, there is some cases that find it really, really difficult, and we're quite fortunate in most teams to have psychology on board, and if we find that parents are struggling so much, then the psychologist can come in and help them to prepare for the birth of the baby.
You as specialist nurses would do counselling with families to help them with that adjustment?
Oh yes, we would identify any anxieties that parents have in that initial period and help them overcome those anxieties. Lots of parents feel quite guilty at having been given a diagnosis of a cleft lip and or palate, and often come up with anxieties. Why did this happen to me? What did I do in that early part of my pregnancy? They're trying to think back and rationalise, did I have a drink while I've eaten healthily? Is it something that I've eaten? Is it something that I've drank, or is it medication that I've taken? And more often than not, it's none of these things, and our role is to reassure families and support them through that time. It is unfortunately just one of those things.
On occasion, it's possible for a cleft lip to be diagnosed antenatally using a two-dimensional scan. This might be during routine screening at approximately 20 weeks of pregnancy or at a later point in the pregnancy. In some parts of the country, it's possible for expectant mothers to undergo a three-dimensional scan. This often produces a clearer image of the baby, providing the lips can be viewed. It means that more detail of the baby's cleft can be obtained. For example, whether the cleft is on one side or both sides, and how far the cleft extends into the lip and nose area. As technology improves over the next few years, it's possible that scanning will be able to provide more information about the cleft. When expectant mothers find out that their baby has a cleft lip, there can be a lot of upset and worry. Some parents report that they're glad that they've been able to know about the cleft before the baby's born. They say that the knowledge helps them to be prepared and to deal with some of the implications of the cleft before the baby's born. Some parents report that the knowledge means that they worry a lot and that the pregnancy is somehow spoiled.
In making this film, you've spoken to a lot of parents who've had babies with a cleft. What's it been like for them?
Having a baby with a cleft is a big shock, especially if you don't find out until the baby's born. The birth of a baby should be a happy, joyful time, but if you find out at the birth, it can be a big shock. And parents react in different ways. Some parents seem to accept what's happened and move on and are okay. Other parents are filled with questions, anxieties, worries. Some parents have said they were really mixed up and confused about how they were going to feel about the baby, in that they didn't want to hold or look at the baby, not sure how they were going to react themselves. Other parents said they felt numb and couldn't take anything on board. But I think it's important to remember that everyone will react differently, and there isn't a right or wrong way in how to react to that news. And feeding's a priority. Most parents have an idea about what they're going to do in terms of feeding their baby and what that first feed might be like. But for babies with a cleft palate, there are specific feeding issues, and you need to be given the most up-to-date and accurate advice. For me personally, I wanted to breastfeed. That was really important. And I was encouraged to put the baby to the breast, and that was lovely in terms of bonding, but useless in terms of feeding. So I needed that advice about how to feed the baby really early on.
It is a really difficult time, isn't it? Is there any particular advice that you feel parents could be given?
I think knowing that the specialist team are there and being advised of that really early on, that your specialist nurse will be coming quite early. Within the first 24 hours, the nurses came to see us. I think parents said about the terminology that was used to describe. They felt very unhelpful to have things like deformity or disfigurement used as a way of describing their new baby. And I was one of the parents who really didn't like their new baby being called the cleft baby, as if that was all there was to your little newborn.
And I guess a lot of professionals who are with you at the time of the birth and those first few stages might not have seen a cleft before. Is there any particular advice you can offer the professionals who are in that position?
I think it's true. A lot of parents have commented on that the professionals hadn't come across a baby with a cleft lip or palate, and they found it quite distressing and quite shocking for them. And I think if they hadn't handled the situation very well after the birth, it was quite distressing for the health professionals. But knowing that the cleft teams are there and that they should be contacted quite promptly, as soon as the specialist nurse comes in, not only can they support the parents to care for the baby and give the advice about feeding, etc., but they can give the correct and up-to-date advice to the professionals that are working with the family as well.
So rather than say the wrong thing, it might be good for them to contact the cleft team as quickly as possible.
Yeah.
Newborn babies have a routine postnatal check which can be carried out at hospital or at home. This might be the time that a cleft palate is diagnosed. The cleft specialist nurse will be notified if she's not already aware that the baby is being born with a cleft. The specialist nurse can make contact with parents once she knows about the baby. She will help parents to adjust to the news of a baby's cleft, give feeding advice, and information about the care that the baby will receive during his or her childhood. She will also be able to support parents and families at this time. Parents usually get the opportunity to come to a cleft lip and palate outpatient clinic before the baby's first surgery. They will usually be able to meet the surgeon who will be doing the baby's operation, as well as the other professionals in the cleft lip and palate team. Cleft lip surgery is usually carried out when the baby is about 3 months old, and cleft palate surgery is usually done between the ages of 6 and 12 months. In cases where the baby's growth is occurring at a slower rate than average, or when the baby has health problems, the surgery may be postponed until the baby is older. Coming into hospital for the baby's surgery can be a stressful time for parents. In the case of cleft lip, by the time surgery comes round, many parents find that they have adjusted to the appearance of the baby's lip and may have mixed feelings about changing the lip with surgery. Many parents say they feel sad about losing the cleft. Taking photographs before surgery and talking about these mixed feelings can be helpful. It's very unusual for a parent not to be anxious when it's time for their baby to go to the operating theatre. Many parents feel upset at this time. Making sure you have some support at this challenging time is really important. When a baby comes back from the operating theatre after their surgery, they will usually look different. Their faces can be swollen, and they might sound different when they cry because their cleft has been repaired and the mouth area has changed. They'll also smell different at first, as the anaesthetic can take a while to come out of their systems. Some babies can be unsettled for a time after their surgery, but others don't seem to have any disturbance at all. Each baby is different. The hospital team will be there to support you. In theatre, the baby will be operated on by the cleft surgeon and their team. Surgery is intricate and can take some time. Other people in theatre are there to help the surgeon and to look after the baby while they are asleep. When a baby has a cleft lip and no cleft palate, there are not usually any special considerations needed for feeding. When a baby has a cleft of their palate, a thorough feeding assessment by a cleft specialist nurse is needed. She will help parents develop a feeding plan and will give guidance and support as parents learn the techniques for feeding their baby. Feeding can be a great source of worry to parents, and it's important that the advice they get is prompt, accurate and individual to meet their baby's needs. In this film clip, the cleft specialist nurse has come to the maternity unit just 2 hours after baby Jasmine is being born by caesarean section. The cleft specialist nurse assesses Jasmine's oral reflexes in readiness for Jasmine's first feed. Jasmine is very sleepy but manages to take some formula milk. The initial feed may be given using a glass bottle and an orthodontic teat. Over time, the milk will be given in a bottle developed specifically for babies with cleft palates. This bottle enables a person feeding the baby to gently squeeze the bottle to push the milk out. This is needed because babies with a cleft palate are unable to form a vacuum in their mouths to make an effective suck. As breastfeeding also requires babies to form a vacuum, breastfeeding is usually not possible. When expectant mothers know antenatally that their baby has a cleft and that there is a chance that the baby also has a cleft palate, provisional plans can be made for feeding before birth. The cleft specialist nurse may recommend expression of colostrum, which is the first milk the breast produces. This production begins before the baby's birth. Although breast milk can be expressed using a breast pump, many mothers who had planned to breastfeed feel very disappointed when they're unable to do so in the conventional way. For some mothers, the feeling of loss about this are very strong. Parents quickly become experts in assisted feeding techniques. When it's time for weaning, the cleft specialist nurse will be available to give advice and support once again. Although parents tend to worry a lot about whether weaning a baby with a cleft palate will be more difficult than an average baby, this is not usually the case. Until the palate is surgically repaired, often small amounts of milk or semi-solid foods come down the baby's nostril. This is because the tissues that normally separate the nasal cavities from the mouth are not in the right place.
Parents often talk about the fears they have about seeing their baby for the first time and also taking them out in public. Did you have any concerns about this?
I did. I was really protective about Cameron, and I knew I would be hurt for him and for me if someone was sort of openly critical about his cleft. But in general, I tried to rehearse scenarios that I thought I would find myself in and how I would respond if someone asked me about his cleft. But in general, people were lovely. They asked questions, obviously, but they did it in a really sensitive way. I do remember one situation, though, where it was quite upsetting. I took Cameron to a children's birthday party when he was still very young, before he'd had his primary lip repair, and a little boy passed a comment, nobody said anything. It was very upsetting, quite hurtful, and I kind of had to deal with how I felt and trying to explain to this little boy what Cameron's cleft was. And I think that could have been better if the parents had taken the time maybe to explain that Cameron had a gap in his lip, but it was going to be repaired. But in general, going out with Cameron, seeing other people, they didn't focus on his cleft. They asked about it and, you know, when the surgery would happen, but they commented on him, a baby, happy, lovely eyes, rather than focusing on his cleft. Why do you think parents worry about that kind of thing so much?
We live in a culture where appearance is valued very highly, and parents always want the best for their children. They want them to be happy. So they tend to worry that if their baby is born with something that makes them look a bit different from the norm, then perhaps they might be at a disadvantage in life. But actually research shows that that isn't the case. And it may well be that parents or other adults do ask questions about the baby because they're curious about the fact that the baby does look a bit different. But it is more to do with the fact that it's a novelty, that they're not used to seeing something like that, rather than anything more negative. So if we are prepared with questions to answer their curiosity, then everything should be fine. So what do you think parents can do if someone does stare at their baby?
I think parents will stare, people will stare, but it's often because they won't have seen a baby with a cleft lip that hasn't been repaired, and it is just natural curiosity. Some parents that I've spoke to said that they kind of had a little response prepared, that they would say that, you know, he was due for an operation and was going into surgery, and other parents just chose to ignore it and just sort of walk away. And I think if anyone was openly critical, my advice would be to be very dismissive yourself and just walk away from that person.
And what helped you overcome your worries about people's reactions to Cameron?
I suppose we just made a conscious decision that we were going to enjoy Cameron's babyhood. Friends and family tell you that they're only babies for 5 minutes, and they really are. So things that we planned to do, swimming, baby and toddler groups, that kind of thing, we went out and did. I did find it hard overcoming the fact that Cameron had a cleft, but I'm not sure that I would have reacted any differently if he hadn't had a cleft, because I think having a baby's hard to get your head around as well. And I used family and friends for support constantly. We had really good support from our specialist nurse who came to see us really regularly. And I didn't really want to put our lives on hold between surgeries. I wanted to get out and enjoy that time with him. I think, and knowing as well that I was going back to work in however many months, that it was really precious time that I wanted to spend with him. I don't even notice his scar now. He's 2.5 now. But I wonder how, if people haven't met him before, how they will react. They might notice his scar, and knowing how children can be, and I wonder how he'll react when he's older, how he'll feel if a child passes a comment or perhaps teases him at school about his scar.
It's important to accept that people will ask questions. So it's also the case that all children get teased and some get bullied about the way they look. It doesn't matter whether or not they've got something which we might call a visible difference or not. So the important thing is to equip him with some strategies for dealing with those questions when they come. And research shows that there is no difference between the distress he might have from being teased about a cleft compared with another child who might get teased about another aspect of their appearance. So it's all very normal. The really important thing is just to give him confidence about how to deal with people's questions and curiosity, and then he can answer the question and just move on.
Guys scared to see the baby for the first time?
No, not at all. I think at the time you don't even think about it because you're still in labour at the end of the day. They put her on me and I actually totally forgot to look because they're that concerned in getting skin-to-skin contact and getting it cleaned up and things. And I was like, oh God, let's just see what it is like. And it was worse than we thought, but it just didn't matter. You know, we were prepared mentally anyway. No,
I mean,
it's fine.
Not to be nasty, but children when they've just been born, they're not in the best state to be looked at anyway. The little faces are swollen, they're red, they're covered in blood and all sorts of nasty things. So, I mean, all that and the cleft involved, it just doesn't matter at the time. You're just so relieved to have your little one there. And I mean, Leonie's lip was slightly worse than we expected, but slightly worse or slightly better, at that point it's irrelevant, because you know what's coming, you know what you need to do. And I think the different extremes of clefts at that point is, like I say, irrelevant, because the processes afterwards are going to be the same. He is your child, and there's no taking that away.
The Cleft Lip and Palate team offer clinic appointments to a child born with a cleft lip and palate until they are about 20 years old. During these appointments, the child will meet members of the team who will be monitoring their progress and who will offer treatment and support where needed. Aspects that will be monitored are speech, hearing, psychological well-being, appearance and dental health.
If a child has been born with a cleft palate, their speech will be listened to regularly by the speech and language therapy team. The team may need to assess the movements of the palate during speech using X-rays. This is called a video fluoroscopy. As a child grows, further surgery may be necessary. One of the important members of the team is the ear, nose and throat surgeon. They will check, along with the audiologist, that the child can hear clearly. Sometimes grommets are needed to help with hearing.
When a child has a cleft of the gum in their mouth, surgery is the only way to repair this gap. The surgery is usually carried out when the child is between the ages of 8 and 12. Often before the surgery can take place, children will need to have their gums prepared by using orthodontic braces. The child will need to be seen regularly by the orthodontist to carry out this work.
Some children have further surgery to their palate to improve how well their palate moves during speech. When growth is stopped, the young person may choose to have surgery to alter the appearance of their lip scar, the shape of their nose, or their jaws. They may want surgery to alter their nasal passages to help with breathing, or surgery to their jaws to make their jaws and teeth meet differently.
As a young person is more mature, decisions about this kind of surgery can be made by them with the support of their parents and the team. The child or adult is usually able to access speech therapy, dental treatment, or psychological support through the Cleft team. Parents and families can also get psychological support for issues to do with the child having been born with a cleft.
It does seem like the end of the world, and it does seem like, oh my God, there is this major problem, but it's not. There's things in place, there's things that you can do when the baby's born to help. And it comes a point after all the operations, you sit and you look and you think, what was all that heartache about when we first found out?
I think the turning point for me was when I realised that they were uncomfortable. It was their problem.
The fact he's got a cleft is a tiny, tiny, tiny little part of what he is. So, and it's something that when he's older is not going to affect him.
Baby, we're so close to each other.
Baby, we're so close to one another.
Baby, we're so close to each other.
Baby, we're so close to one another.
Baby, we're so close to each other.
Baby, we're so close to one another.
Baby, we're so close to each other.
Baby, we're so close to one another.